Welcome back to the next episode. I'm Travis Brashear with Lockton, and we're talking about people solutions. And as I've said in the past, as a tee up to some of these, we're talking to people and getting to know people behind the scenes. We're also talking about solutions and things that we're doing both within our traditional benefits and healthcare practice and outside of that. And today we're excited to be joined by Dr. Christine Hale, who wears a lot of hats within Lockton, but also runs a complex claims unit, which has become a really big deal. So Christine, thank you. Welcome.
Thank you so much. Delighted to be here with you.
Thanks. Well, let's talk a little bit about just your background. I know Dr. Hale, obviously we get that part, but how did you get into this space, and what gets you out of bed every morning?
Yeah, absolutely. Well, it certainly has been a serpentine career path as opposed to linear, but I think that adds real richness to the work that we do every day. So, of course, started as a pediatrician and stayed at Duke and got an MBA after I finished my medical training. And serendipitously got a call from McKinsey and Company to become a consultant with them, which I thought would be a great learning experience if I wanted to affect change in the healthcare system.
Right.
Thought I would go for a couple of years. I loved it. I ended up staying almost 8 years. And then I went on disability, and I was full-time patient for 15 months. And I will tell you, I had no idea what healthcare really was like for patients until I had to deal with my own rare condition.
Yeah.
And that experience really shaped the rest of my career. It really drove me to want to get back closer to impacting specific members. I first came then to a health system, a national health system, and did work on cost containment and quality improvement for 4 years.
Okay.
Had the great opportunity to join Lockton almost 7 years ago now.
It's been that long?
Yeah, it really has. Time flies.
I think I met you maybe with an outside vendor back then,
right?
Like your first week.
Probably so. Yeah, it was pretty early.
It was a long time ago.
Yeah.
So it's been an interesting 7 years for sure. But talk a little bit about what was the impetus for you coming on board? What was Lockton looking at when they said we really got to do something differently?
Yeah, great question. And again, serendipity is always my best friend. So I had a recruiter actually reach out. So at the time, Lockton had a medical director that was retiring. They were looking for a replacement. This recruiter knew me very well and said, I think you'd be a great fit. And I was looking at him like, you've got to be crazy. I know nothing about benefits. And he said, actually, they're really innovating in the space and doing a lot of creative work. I think you should just at least go talk to them. And I will say it's 2 hours of discussion with Lockton, and I was like, sign me up and put me in, coach, because what the team was doing was really starting to impact member-specific issues that are driving a lot of the claims cost.
Yep.
And because of that, you're also impacting the member experience. So it's that real impact on patients. And that's why we all go into healthcare in the first place, right? Is to help people. So this was a really unique way for me to get to help people and save money at the same time. And not everybody can say that they can do that.
Yeah. So tell me about the unit that you've created, starting probably with you as number one.
I was number 4, actually.
Number 4,
believe it
okay.
or not. Yes. So it was a small but mighty team when I joined 7 years ago. The practice started with an underwriter from UHC, a case manager, a nurse, and a coding and claims expert. And I was number 4 as the medical director. And we now are close to 30 dedicated individuals that all we do every day is put on our private detective hats and go in and look at individual members' claims, whether they're currently high cost or likely to head that direction, and try to find solutions that will help that specific member.
So we take our self-funded clients, most of the time that have some stop loss, and we're using our data warehouse and looking at the information coming through that and helping to identify people that we think are going to be in a very complex, high-cost environment and try to step in. When we step in, talk a little bit about sort of that spectrum of we're looking at the claim itself and we're looking all the way to do they have the right provider? Talk a little bit about what you see where the opportunity lies.
Yeah, well, if I can back up just one step, which is how do we open a case, right? That's kind of the first question. And as the audience may not be aware or may be aware that this is a tiny fraction. We're talking 0.5 to 1% of the members that typically drive about 1/3 of plan costs.
Yeah, that's crazy. Right?
I call them the purple zebra unicorns. They are truly the exceptions, which is why population health solutions are fantastic, but they're not necessarily going to be able
Not
to
gonna
address
fix
this
this.
level of complexity.
Right.
So the three ways that we will open a case, one is sheer dollar amount or change in the trajectory, right? If somebody's ticking along at a certain level, we see a big bump in their claims costs, we're going to start asking what's going on.
Yeah.
The second way, which has really been our focus the last 2 years, is we've built out, so InfoLock is our data warehouse,
Yep.
and it has claim level detail on these individuals. My team are the only ones at Lockton that can see that level of detail.
Right.
But because we have that data, we've built out now almost 7,000 triggers
Wow.
that flag cases on first dollar claims basis. So the first time we see a drug diagnosis mismatch or we see a cost that's out of line for a service and we're wondering why, a lot of those are now coming in through these flags or triggers in the system.
Wow, that's crazy.
Yeah, and
7,000.
7,000,
Okay.
I know, right? That's
Yeah.
all homegrown. We've built that all ourselves. We looked around the market, couldn't find what we were looking for, and so we built it out.
Wow.
But the third, and maybe my favorite way, is because through direct referrals from case managers, navigators, and even benefits team members. So sometimes an individual, the first sign that they're struggling and are about to hit some road bumps is they're asking about short-term disability. They're asking about FMLA. That certainly was my case. The train was about to run off the tracks, and I just couldn't work anymore.
Right.
And that was really the first sign. So we always encourage folks, if they see somebody who's really struggling to get through the system, to give us a heads up and see if we can help.
Yeah. And so let's talk about just like dive into, let's, get to the, I don't know, this isn't the sexiest part of it, but sometimes the claim's just wrong.
Yeah.
Yeah. So who sees that and what do we do about that?
Yeah, great question. So to your earlier question also, what do we do, right? We open a case, what is it we do? Well, there's really two main components to our work. So the first is the cost projections that we do. This is the piece that finance often loves because it really helps hone those projections for budgeting and those purposes. But the part we get really passionate about is the go get it, where we do try to actually impact the outcome of the case clinically and from a quality perspective, but also obviously from a cost reduction status.
Right.
So we're going to start when we open that case all the way at the beginning and say, is this, do they have a correct and complete set of diagnoses even?
Right.
Some of our biggest savings have been getting people to some of our referral destinations and getting the right diagnosis so they can get the right treatment. We've had cases where someone had a diagnosis of MS and they are on a $300,000 a year medication. Turns out they don't have MS. That creates a problem with both A, cost that's not adding any benefit, but B, they're not getting the treatment that would actually help them, right? Once we're comfortable with that, we're going to ask questions around the clinical appropriateness of the treatment. Maybe they need access to a clinical trial and we can help with that. But the real cost savings comes in the looking at ways that care can be rendered that are not necessarily the traditional way, but make a better member experience and save money. So that's going to be things like doing that infusion in the member's home instead of in a hospital,
right.
Such things. And then there is the claim is not right. So we're going to do the I dotting and the T crossing, looking at the itemized bill,
Right.
medical records if needed, and just making sure that you'd be maybe amazed at how often it is that we see that somebody fat fingered an extra zero on that bill or coded something incorrectly. And so, having that extra set of eyes to make sure that whether it was deliberate or not deliberate, that somebody's taking a look and making sure everything was correct.
Yeah. And I think we've talked in an earlier conversation where some of the things that we've identified actually helped the carrier change their entire approach
100%.
to the way that they're covering or not covering a certain benefit. Right?
Absolutely.
Yeah.
We had one major carrier that we started seeing some claims coming through. So there's a difference between home health care, which is just getting nursing help in your home. That's typically a short-term solution after, say, an inpatient discharge, right? And then there's folks who need longer-term services that most health plans don't cover, and that would be considered custodial care or private duty nursing.
Right.
And in this case, we were working with a large client, and these cases kept slipping through the cracks, where when we reviewed, we could tell this was private duty nursing, but it was getting approved as home health.
Oh, wow.
And the first case or two, the administrator said, we agree with you, we'll remedy it. And by the third or fourth case, we started to say, is there a broader issue here? Because why do these keep slipping through? through.
Right.
Long story short, there was a provider in their region that had gotten very creative with their billing using a different set of codes.
Yeah.
And it was bypassing the trigger in the system that was to delineate between those two services.
Wow.
So they were getting paid the higher amount. And not only did it save our client $2 million, but it saved multiple millions for their fully insured plan and other clients.
Wow. So a lot of this obviously is around cost, right? I mean, and if you know, our clients that have individual stop loss, managing that over time, like you said, a small percentage is a third of their budget. Yeah. You get people that are sort of ongoing claimants, and you've got to help them. But talk about the personal side of it a little bit. I mean, maybe your favorite story, because at the end of the day, these are humans, right? And they're also, in a lot of cases, really highly important, productive employees, and they're in a really bad place. And so that, at the end of the day, sort of what, as you said, gets us out of bed. But do you have a couple of favorites that you want to share with the group?
Yeah, these are my favorite stories. And there's one gentleman that comes to mind immediately. We were contacted by his employer, by the benefits team, and said, this just doesn't look right. This poor gentleman is in and out of the hospital. He's had multiple brain biopsies and other very invasive procedures. Wow. Poor thing had a history over the prior year of being told first that he had a stroke. Then they said, that's not actually what's going on. We think you have cancer, brain cancer. And then they ended up doing a biopsy and said, well, it's not cancer. We think now that it was maybe an amoeba infection, a rare brain infection. Wow. But we can't tell what organism, so we don't know how to treat it. Meanwhile, he's having progressive loss of his neurologic function, having trouble walking, speaking, writing, everything. And he eventually was told, we don't know what this is. We don't know how to treat it. And you should plan for end of life.
Are you serious?
It was that bad as he was deteriorating. So we were able to fast track him into one of our partners, the Mayo Clinic, at their Florida location. Within 3 days, they figured out that he had a super rare form of multiple sclerosis. So rare that I had to look it up. Didn't learn about it in med school.
Wow.
And they had a great treatment plan. He had the great fortune to live in South Florida, close to another partner of ours, Cleveland Clinic. So we got him in there for ongoing management.
Okay.
And he is back at work, regained his function, and he wrote a letter for their newsletter, their company-wide newsletter, just saying, I want people to know that this is out there because it saved my life.
Wow.
And that's, there's no replacement for that sort of impact.
Yeah. I've been in this business for a long time, and everywhere I go with a team of people, it's like, you've got to realize that you have to believe that we're going to make people's lives better if they work with us because of the commitment that we have around these things. Yeah. All right, so that's one. You said you had two. Share one more.
Well, I have one that's very relevant because the member just messaged us yesterday. And this just goes to show how many ways that the healthcare system can go off the rails if you're not paying attention. So we have another client that I was reviewing their data. So I pulled all the data on their claimants over 100,000 just to see what other trends we could find, and stumbled upon this case that I literally had never seen before. So it was a gentleman who has a severe bowel condition, autoimmune, called Crohn's disease. Yep. That in and of itself is not rare. What's rare is that he wasn't getting any kind of regular treatment or prevention for this, and had gotten so severe that he ended up in the hospital with kidney damage because he was losing a lot of fluid and got dehydrated.
Oh, wow.
So it had just gone out of control. Well, furthermore, when he was discharged from the hospital, they put him on IV normal saline, which for non-clinicians is basically hydration fluid. There's nothing fancy about it. It's the stuff you can get at like a mall clinic, right? For a couple $100. And he was getting it though in a hospital setting several times a week at the cost of $150,000 a year. It's salt water. Yeah, it was like, I've never seen anyone on regular saline infusions for 3 years, and B, I've never seen it done in a hospital for $150,000. Wow. Furthermore, when I talked to the member and his provider, they both had requested it be done at home and were told there were no in-network options for them. So it took us a year, but we finally got an in-home provider. He is now, not only is he now getting the infusions at home, but they trained him to do it himself. Oh, wow. And he is so happy, and the new cost is $30,000 a year.
Okay.
And then we're going to refer him to one of our expert partners to manage his Crohn's disease. But it just goes to show you, member impact. He's much happier. It's much much more convenient. He doesn't have to miss work to go to the hospital. He does it at night when he's at home, and he's happy. Cost is going down, and he'll get better care.
You just wonder how many of those stories are out there.
Exactly.
Right?
You never know if you're not looking for it.
Yeah, crazy. So if you think about the potential audience and the clients that are out there, how do you engage with us around this? Like, some people are our core clients. We give them InfoLock. They have stop loss. They get this as part of that package. But some people aren't our core clients and still have a great need for this. Can you buy this off the shelf? Like, what's the latest update on that?
Yeah, absolutely. That was actually one of my charges when I started, was to figure out a way we could provide this even if a company wasn't ready to pull the trigger on their whole book of business to bring it over.
Right.
So we now serve employers that have stop loss, employers that don't have stop loss, regional health plans. We have a stop loss carrier we do this for now. So the audience has really expanded to have a lot more types of clients. And generally what we'll do in that situation, we do like to have the data. The data and willingness from whoever is the administrator to work with us on solutions is very important. Yeah. But as long as those two pieces are in place, preferably with InfoLock, but we've done it in other cases without InfoLock, as long as we can get that detailed data and get buy-in from the administrator to work with us, then we can price it out in a way that makes sense. And a big portion of that pricing is a percentage of savings, because we want people to pay us if we're having an impact.
Yeah, and if not, we don't need to be paid for nothing, right? But we have good luck so far with most carriers, let's call them partners, at getting the data that we need, even when we don't have a data warehouse or InfoLock in place.
Yeah. I think that the big difference with having InfoLock, without it, oftentimes what we'll get is a 50% report. So, anyone who's, or if you don't have stop loss, it's a certain dollar threshold, right? They may say, well, we'll send you all the claimants over 100,000. Well, that's great. Right. But back to our earlier conversation around triggers, ideally we want to catch these cases before they become very expensive, and that becomes a little bit harder to do if we don't have that piece.
Yeah. Well, this is all, to me, fascinating, and I think the biggest issue that we're facing. There's a lot of other stuff in healthcare, but these claims just continue to get larger and larger and more complex. I don't want to put you on the spot, but what do you see down the road as the next iteration? Like, what happens next? Like, where are you taking this?
Yeah, great question. We do continue to build out what we call our centers of distinction partners. So we currently partner with organizations like Mayo Clinic, Dana-Farber Cancer Institute, and Cleveland Clinic. We're adding more to that cohort to be able to serve members in broader geographies and with different conditions. But beyond that, there's a real opportunity here that we've already started to make progress in, which is partnering with a client's ecosystem. So that would be the collection of vendors, administrator, navigators. How do we integrate more deeply so that A, we can find those cases faster, but B, I always say my job's not to help you figure out which solution you want. We have other colleagues that do that. Right. But certainly, let's take weight management, for example. So if the client has a weight management program, sometimes I need access to that for a member, because if they're overweight and they're on a weight-based specialty drug, that can mean hundreds of thousands of dollars simply because they're higher weight, which means much higher cost. So we're working to streamline that, where we can say, okay, we know, obviously we want everyone who benefits to enroll, but let's double down on these couple that we know would make the most impact for them clinically and for them from a cost perspective, and make sure we're getting that person, that high touch, getting them enrolled, and making sure that piece is being addressed through that ecosystem.
Wow. Okay. So that's the future then.
That's the future.
At this point. So I guess the last question is, like, how do we clone you? Like, how many Dr. Hales are there out there, right? Because you seem to be everywhere.
That is a great question. I ask myself that sometimes. What we've really been doing is trying to work on our model. So we have a concept we call practicing at the top of your license, right? Yep. So I have, for example, a nurse practitioner that has been able to pick up some of what I initially did, and she's very skilled with talking to patients, for example. And so we're really building out our skill set on our team so that the things that others are capable of doing, they can handle. And that allows me to free up for those things where truly, my degree or my expertise will benefit most.
Okay.
Yeah.
That's good to know.
Yeah.
I know you're spread pretty thin, but it's great to know that we've got the resources behind you to take care of this. Well, the last thing that I would say is, if you're a benefits practitioner, in the employer world, should you have any hesitation about identifying people that need help and sending them to the Lockton partnership at this point? How does that work in the real world?
Yeah, that's a great question. So there's both on the identification side and then I think on the outreach side. So first of all, I would say 90% of our work is invisible to members, right? If we're finding a bill error or something like that, that's all corrected behind the scenes. Right. Certainly when it comes to identification, I should say there should be no hesitation. Now, I have some teams I work with in the benefits space that say we don't want to know any of the personal health information, which means we just need a closer partnership with their administrator, for example, to help hotspot cases. Right. But certainly there should be no concern about referring someone to us if the benefits team knows about it, because we do have that training in how to manage that data. And our biggest concern then is if we do have to outreach the member, who does that? Because we don't want to cold call people. Mostly they won't know who Lockton is, and that can be a little bit creepy to hear there's a doctor out there that knows all my data.
Or you're a broker.
That's right. And they're like, who's Lockton? Yeah. So we will typically request that someone, either the administrator or the benefits team member, we've used on-site clinic staff and other ecosystem partners to do that initial warm touch to say, do you need some help? And if so, let's connect you with this special team of experts for complex cases. Yeah. And then it's a little more familiar and less scary for members to engage.
Great. Well, thank you for being here and taking the time to help us get some clarity around what we're doing. If you're listening today and you have an interest and a need to address so your highest cost claims, your complex claims, know that we've got this model out here. Dr. Hale's always on the phone talking to people about it. If you want to just have a conversation, reach out to me or Dr. Hale. And thanks for joining, and we'll see you on the next episode.